Hello, everybody. Not everybody's back from lunch yet, which is too bad because this is a good talk. It's one of my, thank you. It's one of my better ones. We'll see. I'll add a little flavor. So, I constantly argue with my friends who have Android phones. You know, like, why do you have an Android phone? You should have an iPhone. iPhones are the best phones. And then the Android phone people always argue with me. So there's always this argument over which phone is better. But if you really kind of lift up the hood and talk about the phones themselves, it's easy to compare some aspects of the phones, right? You could compare storage, because that's inherent to the phones. You could compare their cameras. You know, how many pixels does this have versus this have? What kind of imaging does this have versus the other? But there are other things that are inherent to the phones there are other things that are not inherent to the phones that might make comparing them difficult. For instance, maybe one phone has a very good service provider who maybe provides LTE, whereas the other phone may have, 3G, and then they don't perform as well. So there's certain things about a technology that's inherent to technology that's easy to compare, but there's other things, confounders, that I think you have to be aware of. So when you're comparing two technologies, you're actually comparing two technologies. So when you're comparing things and you're using the data, which is what we do, to compare things, you always have to be skeptical of that data. Performance is only as good as the integrity of the data. You know, we have this term, garbage in, garbage out. When you interpret the data, you have to be critical of its integrity. How are the endpoints defined? Are there hidden confounders that are behind the scenes that you don't really see in the study that you should be looking for to try to pick up? And did the data reflect real-world conditions, the conditions that you have in your own individual practice? Any procedure with diagnostic intent, right, is contingent on three things. The diagnostic test, the performance of that diagnostic test itself, the technology performance, and also the operator performance. So for instance, if you're talking about a robot, right, there's the robotic performance, but there's also the performance of the person doing the robot. And then, after that robotic bronchoscopy, you have so many other things that come into play before you get to your procedural outcome. Now, unfortunately or fortunately, procedural outcome, for better or for worse, for us, is diagnostic yield. It's been diagnostic yield forever. So, taking these and applying it to diagnostic yield, I have a technology that I'm going to try to access a peripheral lung nodule with. That technology has its own performance. I have my own performance using that technology. I do the biopsy, and then many other things come into play before a diagnostic yield comes out. So that diagnostic yield, right, is the number of results with the desired outcome over the total number of tested. But it's that desired outcome, that's the question mark. What do we define as that desired outcome? So when you're comparing outcomes, you want to make sure not to compare apples with oranges. You want to compare apples with apples. There are things that are very clear, right, when you look at a study. Size, location, biopsy tools, CT to body divergence. You could see these things. They're listed. They're very obvious. But there's some things that are hidden behind the scenes that may not be reported. Not so obvious. The expertise of your pathologist. How you define the outcomes of that study, the prevalence of cancer in your cohort, and actually the expertise of the operator doing the procedure itself, right? If the operator isn't very experienced versus the operator being experienced, it's going to significantly affect your yield. So why define diagnostic yield? Why are we spending so much time on this lately? Well, multiple studies report many different types of outcomes. The most commonly used outcome being diagnostic accuracy or diagnostic yield. Like I said before, this is what we do. We compare studies by diagnostic yield in this space. Application of what qualifies, however, as a diagnostic yield is very variable across the studies, and I'm going to show you this in a little bit. These variable definitions of diagnostic yield influence the interpretation of the study results, and it really limits the ability to compare one study with another study. And these variable definitions primarily differ in their approach to categorization of cases that are negative, right? Positive's easy, negatives, how do we define those? And we'll talk about that. So this group got together, a group of the minds, of the best minds of the best minds, and they decided this is what we feel diagnostic yield should be. And they listed their reasons for that, and it's all of the reasons we just stated, that a major issue in diagnostic bronch literature relates to the variable reporting of diagnostic yield, right? Everybody's using different definitions. And they made this statement to propose a research framework to standardize the evaluation of advanced diagnostic techniques for peripheral lung lesions and ultimately provide a level of evidence required for successful and rational integration of novel technologies in clinical practice. Basically saying, if you're going to publish a paper in our journals, these are the rules we are going to apply to you. These are the rules we want you to follow. And specifically, they proposed a very robust consensus definition of diagnostic yield, and they discussed potential study designs for evaluation of novel bronchoscopy technology, various stages of introduction. Again, they're trying to define diagnostic yield. However, the subtext here is there's a lot of new technology coming out, and we're going to tell you how to define diagnostic yield or define ways to compare those technologies, because we don't like the way you guys are doing it right now. So let's talk about handling definitions of yield, right? Diagnostic yield clearly is true positives versus true negatives over total cases. True positives, in our sense here, specifically with that definition, true positives always refer to a malignant diagnosis. The entire diagnostic yield is based around malignant disease. A diagnosed malignancy always considered a true positive. Negatives can be categorized in several different ways, and how you categorize these impacts the type of diagnostic yield definition. A specific benign diagnosis, a non-specific benign diagnosis, and a non-diagnostic result, and we'll go through this. How strict we are, again, with defining these negatives is going to define what type of yield you use. So 3 diagnostic categories were proposed: specific malignant diseases, which we already talked about, specific benign diseases, you could see the list here, and then non-diagnostic test results. You could see the examples that they gave on the 3rd column. This, very easy, we all know this. Specific benign diagnoses, obviously hamartomas, benign tumors, organizing pneumonia, fungal disease, where you actually have the fungus, mycobacterial disease, where it grows in culture, or you see the mycobacteria on the stain, and granulomatous inflammation. Non-diagnostic test results include these, and we'll talk about the specifics of these in just a second. So strict yield is our outcomes based on the results at the time of the index bronchoscopy. So you do the bronchoscopy, you get a result, and that's what contributes to the strict yield definition. Only procedures with specific benign diagnoses at index are considered true negatives. Obviously, if you find malignant disease, it's a true positive. Cases with a non-specific diagnosis or a non-diagnostic result are not considered true negatives, so therefore, in this case, diagnostic yields calculated as true positives, specific benign diagnoses divided by total procedures. Intermediate allows for inclusion of follow-up data for cases, but only those with a non-specific finding at bronchoscopy. Okay, so non-specific findings are assessed longitudinally, either with surgery or follow-up radiography. However, cases in which a definitive diagnosis is not established because of a lack of follow-up are considered non-diagnostic. So if you never did the follow-up, you're non-diagnostic. And here, diagnostic yield is calculated as true positives, specific benign disease, non-specific true negatives divided by total procedures. The liberal classification is exactly what it is. It allows for inclusion of all follow-up data on all cases that are negative for malignancy at index bronchoscopy. So that is any kind of specific benign, non-specific benign, or even non-diagnostic findings can be considered diagnostic if any of the following is true. That is, you have a biopsy that confirms non-malignant disease, or you have radiographic follow-up where the nodule shrinks. The problem with this is that you could completely miss the nodule during your procedure. Let's just say I'm doing a bronchoscopy on somebody with a histonodule that's in the right upper lobe, and for whatever reason, I biopsied the right middle lobe. It happens. Not to me, but it happens. And let's just say that nodule goes away over 6 months, because that's what histoplasmosis does. According to liberal diagnosis, you had a diagnostic yield, and that doesn't really make sense. So this is a summary of what we just said. And here's the important thing. In this statement, they went back and looked at the literature, at least back when they wrote this in 2022, and they said a recent systematic review of on the diagnostic performance of NAV-bronch in peripheral lung nodules include 95 studies. A quarter used strict definition, 32% an intermediate, and a quarter used a very liberal definition. In 16% of the cases, they didn't even list a definition of what their yield was. So this is a problem. It's a problem when you're trying to compare studies, especially now when you have all these new technologies coming out, all competing with each other, each saying that I'm as good as you, I'm better than you. This is how diagnostic yield could really get dicey. Okay, this is a hypothetical cohort where they included a bunch of malignant nodules, a bunch of specific benign nodules, a bunch of non-specifics and non-diagnostics. And you could see that depending on how you apply your definition of diagnostic yield, you could have a diagnostic yield as high as 89% and as low as 66%. A huge swing in diagnostic yield depending on the type of filter that you use. And here we are. Here's a perfect example, the Navigate trial, one of the most historic trials in our space, right? Done on old superdimension. They reported a 12-month yield of 73%. It was a very liberal definition of yield. If you apply a conservative yield filter, their yield suddenly drops to 53%. Again, a coin flip. They spent $2,000 on a procedure that they could have easily handled with 1 penny. You have cancer. That one, think about it. Yeah, you laugh, but it's the coin flip, right? Okay, so let's just focus a little bit on specific, non-specific, non-diagnostic test results. Look at these, atypical cells, okay, I give you that, but acute inflammation, I mean, I think if I do a bronchoscopy on something that has acute inflammation, even if I didn't find a bug, I would kind of think that I'm lesional. Acute is something that doesn't belong there. Necrosis, again, something else that doesn't belong there. However, the authors decided to make these non-diagnostic because they say that you could still see this in malignant disease, therefore this could be misleading. We're going to consider it non-diagnostic. So again, some people feel that's overly strict, but this is why they did it. And they gave us a couple out clauses. They gave us suggestions. Thank you, authors, for giving us those suggestions. They said first, you could do longitudinal follow-up studies, and that could be used to express diagnostic accuracy. Well, or you could do studies to determine the impact of these non-diagnostic test results, such as acute inflammation, to see if they ever have any impact down the road. Okay, well, thank you for that. Maybe we'll do that. This is a study that came out of Vanderbilt. And what they did is they looked at diagnostic yield on index procedure, okay? And then they had 2 years of follow-up, so diagnostic accuracy. And they wanted to see what the difference was between the yield and the accuracy. Was that, delta significant? And you could see the y-axis here, right, is the discrepancy between the yield and the accuracy. And you could see when they applied conservative yields, very strict yields, yield definitions, that the diagnostic accuracy didn't really change much. But again, once you start getting less and less strict with your diagnostic yields, your discrepancy is super, super high. Now, I think how you might want to say, well, this is great, but I think this kind of creates more questions than answers. And for these reasons. First of all, a true positive comes from the point of view of only malignancy, right? I get asked to do biopsies for patients that are clearly not malignant, but I have patients who have rheumatologic lung disease on immunosuppressants. They develop a nodule where infection is part of this differential, a large part of the differential. If I do a biopsy, I don't find malignant cells. Does that mean I have a non-diagnostic yield? Okay, and is this really the only patient-centered outcome that we have? And we're going to talk about that a little bit later. The assumption that all nodules have the same malignant potential is inaccurate in many instances. And we talked a little bit about this during my talk yesterday. Size, cancer prevalence, geographic locations all play a very significant role. If you do a clinical trial in Cleveland, Ohio, where we have a lot of fungal disease and try to compare that to a clinical trial done in New York City where they have no fungal disease, where their cancer prevalence is high, my cancer prevalence is relatively lower. How do you compare those two outcomes? We showed this yesterday. This is the impact of cancer prevalence on diagnostic yield. Again, if you use a very strict, that's the green line above, you use a very strict definition, it doesn't impact it too much. But the more liberal you get, the more your cancer prevalence really impacts your diagnostic yield. Nodule size also really impacts your diagnostic yield. Because look, if you have two sets of nodules, ones that are over 20 millimeters in size versus ones, say, under 15, very significant impacts on probability of malignant disease. Now, my Galaxy trial that we presented at CHEST, our average nodule size was 12 millimeters. The first Deckel ion trial by Deckel at Sloan Kettering, their average nodule size was around 20 millimeters. How do you compare those two diagnostic yields when the pretest probability of malignancy was so different in the two groups? I think that's a problem. Diagnostic yield is also compounded by factors unrelated to the technology. We call this, Kyle coined this term, the Tiger Woods clubs paradox. So just because I use Tiger Woods golf clubs doesn't mean I'm going to shoot a 66, okay? I'm still going to shoot 110. Maybe 120. So just because you have the best technology, if the operator who's using it is not very good and not very skilled, that technology is going to have a poor outcome. And we don't really assess for that, right, in clinical trials. Nobody says, hey, we did a clinical trial on 300 nodule patients, and the operator was somebody who's been doing this for 20 years. Nobody says that. Nobody says, hey, I've been doing this for 3, and I had a bunch of fellows doing it. So these are things that are never written in the clinical trial, but it could be quite impactful. And what do we do about this, right? What do we do about that 75% of studies that didn't use strict definitions in the past? Do we just throw them away? Do we go back and recalculate all their diagnostic yields and republish them? I mean, I think this is a big problem. So I think it was nice that they created these definitions of strict diagnostic yield and say this is how we're going to move forward, but they didn't give us any guidance on how we mitigate what happened in the past. So what are the alternatives? Well, certainly diagnostic accuracy is one way of looking at things, right? And the accuracy is the ability, measures the ability of a test to detect a condition, right? When it's present, to rule out a condition when it's absent, right? It's very basic. So the problem with diagnostic accuracy is that it could only be determined after a follow-up period, which could really delay reporting, especially on new devices. This really impacts what I was talking about yesterday with how do we get new devices to the market? Do we wait 3 years for diagnostic accuracy numbers to be published, right, or to be found? And I think there's less clinical utility. This is less patient-centric, right? A patient comes in for a procedure. They want to know, like, a week later, do I have cancer or not? Did you get a diagnosis? They don't want to necessarily wait 6 and 12 months. So again, when you report this, you have to kind of put it into the perspective of your clinical practice. What about tool and lesion? We talked a little bit about this in some of my other talks as well. I think tool and lesion is the best gauge of technology performance if you have the ability to measure it. It accurately reflects exactly what the technology was supposed to do. It got your scope or your catheter with a biopsy tool into your lesion. Everything else after that has nothing to do with your technology. But again, it's not exactly pragmatic information for the referring doc or the patient. Hey, Mrs. Jones, I got a tool into the lesion, but I don't have a diagnosis. I mean, so I feel good that I did good, but she feels terrible because she still has no idea what's going on. Yield, we talked about yield, and it's a product of several factors in addition to the technology performance that is just, there's confounders here that we just can't measure. The tool performance, the strength of your cytologist, a huge issue in the United States right now is that 80% of people have lousy cytologists, if they have cytologists or pathologists at all. There's technologies being developed to substitute for them. The quality of the tissue that you get depending on the type of biopsy tool that you use. Are you doing cryobiopsies? Are you doing needles? Are you doing brushes? We already talked about the prevalence of cancer and benign disease. I think the tool and lesion is certainly the best gauge of diagnostic, of technology performance. It accurately reflects exactly what the technology is supposed to do. So look, if we're in the business of comparing technologies, if that's what the authors want to do, which is what they kind of hinted at, well then maybe they should use more relevant outcomes that are specific for the technology. Again, we talked about the cons of doing this just earlier. And look, does tool and lesion equal yield? And Mike Pritchard talked about this before. There's always this 10 to 20% difference between having a tool and lesion and actually having a diagnostic yield. Does that mean all of those cases were benign diseases that we wouldn't have been able to diagnose anyway? Or is that just because of all the confounders that exist? Nobody knows. So where do we go from here? So I think right now we're stuck with the strict definition of diagnostic yield. We're stuck because it's been dictated to us, at least for publications. But diagnostic yield, again, it struggles to compare technologies when so many of these other confounders exist. All these things that we just can't control, and the only thing that we control is how we report. So what are the solutions? Well, I think we have an opportunity to be more pragmatic with assessments of diagnostic accuracy, but again, this takes time. Sometimes up to a year. It could really delay, our publications. Should we be looking more at tool and lesion, like I mentioned? But can tool and lesion actually be a predictor of outcome? So let's just say I give a radiographic proof that my biopsy tool was in the lesion. I got lesional tissue. So what if I got a non-specific diagnosis? How often does that turn into cancer? Because that's what we really care about, right? We care about a false negative for cancer. So does tool and lesion actually have a very high negative predictive value? I think these studies are easy to do, and we should do them. So with that, I'll leave it there. I'll take any questions if you have it. Otherwise, we'll keep moving forward.